sternoclavicular joint manipulation and upper extremity joint mechanics. Sternoclavicular technique. To perform a sternoclavicular SC joint manipulation, the patient should be placed in a supine position on the plinth. The practitioner stands on the side of the joint to be treated, facing the patient with a staggered or asymmetrical stance to ensure optimal mechanical leverage and stability. The therapist's left hand is used to stabilize the sternum, positioning the left pisiform directly on the sternum, while the other hand, using the right pisiform, is placed over the medial end of the clavicle. The patient is instructed to take a deep inhalation, followed by a full exhalation. It is at the very end of the exhalation phase, when the tissues are most relaxed, that the barrier is engaged. At this point, lateral compression is simultaneously applied to both the clavicle and the sternum. Once the restriction is fully engaged and tension built, the manipulation is delivered using a rapid yet controlled thrust. Clinical considerations for the SC joint. When applying pressure to the sternum, practitioners should ensure their contact is below the sternal notch and that their fingers are pointed away from the patient's throat. This positioning avoids discomfort or compression near the trachea. Timing is critical, as the moment between barrier engagement and thrust is brief. Care must also be taken not to apply pressure over the distal insertions of the sternocleidomastoid or scalene muscles to prevent pain or adverse responses. Contact should be maintained solely on the anterior clavicle surface. Chapter 14, Manual Therapy of the Elbow, Wrist, and Hand. Overview. Over the past 100 years, manipulative techniques for treating upper limb dysfunctions have become increasingly popular. Presently, high-velocity, low-amplitude thrust techniques, HVLAT, are commonly employed as adjunct therapies for a wide array of upper extremity disorders, ranging from lateral epicondylitis and nursemaid's elbow to carpal and cubital tunnel syndromes, as well as cases of post-traumatic elbow rigidity. Proponents of manual therapy view manipulation as a generally safe and effective therapeutic intervention for addressing neuromusculoskeletal dysfunctions of the upper limb. These clinicians suggest that many individuals with biomechanical dysfunctions benefit from carefully selected manipulative procedures. The objectives of such interventions include reducing inflammation, relaxing hypertonic muscles, realigning joint structures, offloading excessive force in dysfunctional tissues, promoting efficient healing, and enhancing strength, range of motion, and endurance across the upper extremity. Saunders et al., 2015. Practitioners adapt their techniques based on the specific joint and pathology being addressed. Their approach emphasizes techniques that are both well tolerated by patients and yield maximum functional gains. In general, two primary strategies are used: HVLAT and Mobilisations. Limitations and risks. Despite the growing application of these techniques, the current scientific evidence supporting upper extremity manipulation remains limited. Braunfort et al., 2010. Research evaluating the clinical benefits and risks associated with manipulative therapies in the arm, forearm, and hand is still in development. Accordingly, clinicians are advised to proceed with caution and should always evaluate for red flags or absolute contraindications before performing any manipulative technique. Proper application of manipulative interventions requires not only a thorough understanding of regional anatomy and biomechanics, but also considerable technical proficiency, sound clinical reasoning, and supervised experience. Education and training in manual therapy are essential for minimizing potential risks and optimizing patient outcomes. WHO, 2005, Ernst, 2007, Brantingham et al., 2013. This chapter aims to equip practitioners with the anatomical and diagnostic knowledge necessary to identify red flags associated with upper extremity manipulation. As the shoulder complex has been discussed in a previous section, this chapter will focus primarily on the elbow, wrist, and hand. Joints of the upper limb. The upper extremity, extending from the shoulder to the fingertips, includes the elbow, forearm, wrist, and hand. The elbow, as a pivotal link, connects the shoulder and the hand and enables strategic positioning of the hand in space. Its functions include providing stability, enabling hinge-like movement for flexion and extension, and allowing for forearm rotation. movements crucial for daily tasks and fine motor activities. Alcid, Ahmad and Lee, 2004. The wrist and hand are complex and dynamic, consisting of numerous bones, tendons, ligaments, and muscles. This structural intricacy allows for high degrees of dexterity, manipulation, and functional interaction with the environment, such as gripping, object handling, and nonverbal communication. Doyle, 2003. Anatomy and function of key joints. Elbow complex. The elbow is a compound joint comprising 3 articulations encased in a single fibrous capsule. Humeroulnar joint. A synovial hinge joint formed by the articulation between the trochlea of the humerus and the trochlear notch of the ulna. It allows flexion and extension of the forearm. Humeroradial joint. A ball and socket-like articulation between the radial head and the capitulum of the humerus. This joint contributes to both flexion, extension, and rotational movements of the forearm. Superior radioulnar joint. A pivot-type synovial joint located within the elbow capsule, formed between the radial head and the radial notch of the ulna. It facilitates forearm pronation and supination. Wrist and hand joints. Radiocarpal joint. The main articulation between the distal radius and the scaphoid, lunate, and triquetrum bones of the wrist. It allows for wrist flexion, extension, abduction, and adduction. Intercarpal joints. These synovial joints exist between individual carpal bones and are subdivided into proximal, distal, and inner row articulations, contributing to wrist mobility. Mid-carpal joint. An S-shaped joint between the proximal and distal carpal rows. It supports the initial phase of wrist flexion and extension. Carpo-metacarpal joints form between distal carpal bones and metacarpals. These joints, stabilized by ligaments, contribute to the palmar arch system. Intermetacarpal joints, plain joints between metacarpal bases, reinforced by dorsal, palmar, and interosseous ligaments. Metacarpophalangeal joints, condyloid joints connecting metacarpals and proximal phalanges. They permit multi-directional finger movement, including circumduction. Interphalangeal joints, hinge joints within each finger, divided into proximal and distal IP joints. They allow for flexion and extension of the digits. Elbow joint range of motion. Given its structural complexity, the elbow permits a coordinated range of movements across its 3 articulations. These motions facilitate the placement and functional use of the hand. The typical range of motion, ROM, values are as follows. Villasneer Ovias et al. 2012. Flexion, 104 degrees to 150 degrees. Extension, 0 degrees. Pronation, 76 degrees to 84 degrees. Supination, approximately 80 degrees. These measurements reflect the elbow's critical role in functional activities, such as reaching, lifting, or rotating the hand.